Hi y'all, today we're going to do a high-yield review of obstetric drugs that you need to know for step one. The goal here is not to exhaustively go through all of the pharmacology, but instead just to look at the basic mechanism, the indication, and the common adverse effects that might show up on your exam questions. I'll be splitting this into three parts. I'm going to talk about uterotonics, which are used to stimulate labor, or in the case of postpartum hemorrhage. Then I'm going to talk about tocolytics, which are used to relax the uterus and slow down delay labor, and then just go over a few common prophylactic drugs that might be given in the interpartum period, depending on the status of the mom and the baby. So, oxytocin is a posterior pituitary hormone and a first-line uterotonic. It binds GQ coupled receptors and increases intercellular calcium, leading to uterine contraction and also postpartum milk ejection. When you're going to see this on step one is either for induction or augmentation of labor, and it also can be used to prevent and treat postpartum hemorrhage. The side effects that you really need to watch out for and might be asked about on an exam are uterine tachysystole, which is when the uterus clamps down too many times too quickly, and this can cause fetal distress. You can also get hyponatremia in the mom due to the ADH-like activity of oxytocin. And the key thing that you really should remember is that oxytocin is first line for postpartum hemorrhage after delivery. Next, let's talk about the prostaglandins. Dinoprostone is used for cervical ripening prior to induction of labor. Carboprost is used for postpartum hemorrhage, especially when you have a case of uterine atony when oxytocin has failed. But this is really contraindicated in women that have asthma due to its bronchoconstrictive effects. This is a really common exam question. Please remember that in a patient with asthma, you should not give this drug. Misoprostol, you know her, you love her, she's everywhere on exams. In OB, this drug is used for cervical ripening and postpartum hemorrhage. It's also importantly used for medication abortion. You might also remember from your GI unit that it can be used to prevent NSAID-induced ulcers, but for the reason that it can cause abortion, it is considered a Category X drug when used during pregnancy for ulcer prevention. Methylorgonavine, it's also known by its brand name Methergin, can cause sustained uterine contractions via alpha adrenergic and serotonin receptor activity. It's another second line drug that can be used in postpartum hemorrhage. You'd maybe want to use this if you had a patient who had asthma, who was contraindicated to use carboprostin. A major contraindication for Methergin, though, is hypertension or preeclampsia in pregnancy. You don't want to have unopposed alpha adrenergic stimulation in patients that are hypertensive. Now we're going to talk about the drug class of tocolytics. These drugs relax the uterus or tell the uterus to stop contracting, and they hopefully are able to delay preterm labor. So nifedipine is a calcium channel blocker. It's the most commonly used in this drug class, and it can have minor adverse effects that are usually hypotension and flushing. So just be on the lookout for this in patients or maybe in a question stem. Indomethacin is used less commonly due to its adverse fetal effects, but it can be helpful for some patients that nifedipine isn't working in because it uses a different mechanism of action by decreasing prostaglandin synthesis, which is part of what gets the uterus contracting during labor. This is typically used before 32 weeks, and it can cause premature closure of the ductus arteriosus and oligohydramnios in the fetus, which is why it's not preferred, but sometimes it's the best we've got. Terbutaline, a beta 2 agonist, it can cause tachycardia, tremor, and hyperglycemia in the mom. Magnesium sulfate, it's not a primary tocolytic on exams. It's actually used for seizure prophylaxis in preeclampsia and eclampsia. But in real life, it actually can be used with these other drugs to try to put the brakes on labor. But the important thing that you need to know right now is that it really is given for fetal neuroprotection. And you might also see this in the context of a question about preeclampsia or eclampsia, and especially if the patient's preterm, what you could do to take care of the fetus. Now I'm going to talk about some prophylactic steps that you might want to take in the case of, maybe we do our best to stop labor, but sometimes the baby's just going to come out anyway. And how do you get ready for that birthday? So one thing that you need to do in a preterm patient is give them antenatal corticosteroids, and that can accelerate fetal lung maturation by increasing surfactant production. Importantly, this is before the baby's born. You're giving this IV to the mom. I've seen questions that ask things like, what do you do before the baby's born and what do you do after? Afterwards, you can give the baby artificial surfactant to help accelerate their ability to breathe on their own. There are three other drugs that I want to discuss that are important for prophylaxis during labor. GBS prophylaxis is given intrapartum, not antepartum. The first line is penicillin G or ampicillin. You're going to have a positive GBS screen at 36 or 37 weeks, and an unknown status might also make you want to give prophylaxis just to make sure that the baby is safe. The goal is preventing neonatal early onset sepsis and meningitis. Now, what about if mom is HIV positive? Pregnant patients with HIV should receive combination antiretroviral therapy throughout their pregnancy, but the key intrapartum drug is cidovudine. And this is especially important if the viral load isn't adequately suppressed in mom, although many guidelines now say that even if the viral load is adequately suppressed, there's reason to still give this drug to protect the fetus. If the viral load is greater than 1,000 copies per milliliter when the mom is nearing delivery, you want to do informed consent and talk about a C-section because that might be what's safest for the baby. Neonatal prophylaxis, cidovudine can also be used after birth. What about a patient that has HSV? Pregnant patients that have a history of genital HSV should receive acyclovir or valcyclovir starting at 36 weeks. And also, if there's an active genital lesion at delivery, it's often safer for the mom and the baby to do a C-section to prevent neonatal herpes.